Welcome, everyone. I'm Thomas Sir. I'm the CEO of Kinexum. Today's Kinexum webcast features James D. Carroll, founder and CEO of THOR Photomedicine, on why photobiomodulation, a light therapy medicine, might be the answer to the opioid crisis. Before we get started today, I want to throw the mic over to Kinexum founder and executive chairman, Zan Fleming.
Well, thanks, Thomas. I'm really looking forward to James' talk. I wanted to thank my longtime friend and neighbor, Scott Faulkner, a distinguished force in his own right, for facilitating this presentation from James, which will be very important for all of us to have the opportunity to view. I did want to thank Thomas for an amazing accomplishment last week. Some of you attended or may have heard about the Metabesity Conference at the Carnegie Institute in Washington. It was a success beyond all expectations, and a good part of that was due to Thomas, who not only orchestrated the program, but was very much involved in all the logistics, along with the support of our great young associate, Jennifer Joel. And between those two, working on a daily basis, it was truly an amazing accomplishment. The meeting I'm attending today is sort of a logical extension of that conference. It's over at the National Medical Military Center in Bethesda, and I won't go into the details, but it all has to do with health span and the biology of geroscience. So more to be said about that, but just wanted to thank Thomas and Jennifer and again, James and Scott Faulkner. Thanks so much.
Wow. First of all, can everyone hear me? Just someone say yes.
No.
Hello?
Clear. Yes.
Okay. Thank you. Gee, thanks very much for your kind words. Let's launch into the webcast here. There are a couple of housekeeping points first. First, James will be sharing slides as he talks, so if there are folks who are only calling in, it would be best if you could log in. For best sound quality for everyone on the call, we'll be placing your microphones on mute until the Q&A. Second, in order to access the presentation slide deck, you may need to accept offers that should have popped up on your computer screen from James or from our Kinexum associate, Jennifer Zhao, for them to share their screen with you. Three, if you have any questions along the way or at the conclusion of the presentation, please enter it in the chat box that you can open up on the right of your screen. It's an icon down the vertical strip. I guess you need to get off of the shared screen version in order to access it. It's a rectangular comment bubble icon, and the speaker will answer as many as we have time for. Fourth, a recording of this webcast with slides will be posted, and a link will be distributed to registrants of this webcast within the next several business days. And finally, please be on the lookout for information on our December 13 webcast on the development of botanicals, featuring Kinexum's Jinhui Dao, a natural products scientist and former pharmacologist at the FDA. And with that, I'd like to introduce James. You have the mic.
Thank you very much, Tom. Okay. Why photobiomodulation might be an answer to the opioid crisis. First of all, disclosure. So I am an electronics engineer. I was designing equipment for radio stations, so that's my technical background. I'm also founder, CEO of THOR Photomedicine and shareholder. So I'm not a scientist or a doctor, but I do have 32 years experience in this field since 1987. I've been a co-author of 22 papers in this field, 6 of them with Harvard Medical School, so Brigham Women's Hospital, the Wellman Center, MGH, Harvard School of Public Health. I've helped them write 4 academic books on this topic as well. My expertise in this field is in dose and beam parameters. I've been an expert reviewer for most of the papers that have been published in this field. I'm a co-chair of the Biomedical Optics Society Conference on Photobiomodulation Mechanisms. and I joined a couple of other interesting clubs. And now we have been or currently collaborating with 52 different universities around the world on this topic. So my agenda today, I'm going to start with talking about the opioid crisis. We'll then progress to what is this photobiomodulation treatment and how does it work? Evidence from randomized controlled clinical trials. Of course, we have to deal with safety, contraindications, and side effects, and a little mention of reimbursement, and then how some of the implementation challenges for this technology. So regarding the opioid crisis, we don't need much reminding. The numbers are huge. I mean, they are, you get inconsistent numbers, but they are big numbers, whatever they are. So the numbers I'm getting here from CDC and are that there are 100 million adults in the United States who are affected by chronic pain. Over $600 billion a year are spent on healthcare costs related to pain and the lost productivity. There are about 49,000 deaths associated with opioids in 2017, 19,000 of which just come from prescribed opioids in 2016. And according to the Assistant Secretary for Health, you cannot solve the opioid crisis without solving the pain crisis. And of course, opioids are not the only pain medication associated with side effects, but of course, non-steroidal anti-inflammatory drugs, acetaminophen, are alternatives that have their own pain problems. So what is, first of all, I intend to show today that photobiomodulation is not just a new form of pain relief, with its advantages in that it's non-invasive, it's non-toxic, it's not addictive. The effects can be long-lasting, and hopefully that becomes apparent later on. There are additional health benefits to using PBM, which is the short name for photobiomodulation. And that is because it actually helps people heal. This is a regenerative technology that just happens to have some anti-inflammatory and some analgesic qualities as well. So what is photobiomodulation? Well, for those of you who are old enough, and for those of you who are not old enough, I have to tell you that this TV show in the 1960s and 70s that your parents or maybe your grandparents used to watch, something called Star Trek. On Star Trek, when somebody was injured, they go to see the doctor, and the doctor would get out a laser beam and aim the laser at the injury. The tissues would heal instantly. So that is photobiomodulation. Obviously, it's not as fast as on TV. You get the idea, though, that we shine light on people and they get better more quickly. Unfortunately, the nomenclature is really diverse. I found 79 different names for this therapy, which makes it hard to look up on PubMed. And up until to the end of 2017, the leading term on PubMed and the internet generally was low-level laser therapy, or low-level light therapy, or maybe LLLT for short. But it was widely agreed that this is a bad name for this therapy, partly because it doesn't have to be a laser in order to work, but also it doesn't sound great when you say to a patient, would you like a low-level laser therapy treatment? Doesn't sound cool. And also, it's a tongue twister for you and your patients and colleagues to keep saying low-level laser therapy, low-level light therapy, LLLT all the time. So it was agreed at a committee meeting in DC that we should adopt a shorter, simpler, more pronounceable, catchy term that just trips off the tongue. So that's how we came up with photobiomodulation therapy. That was a joke, except it wasn't a joke, because that really is the name we chose. But it's clearly not a short, catchy term, but it better describes the medicine. So photo means light, bio means life, and modulation means we can stimulate or we can inhibit. And already a shorthand version of the name is being adopted, which is PBM or PBMT or PBM therapy, It seems to be, and since, by the way, since in 2018, it became the leading term on PubMed for this therapy. So what is this therapy? It's the application of monochromatic light, which means light of one color, because lasers and light-emitting diodes will produce this monochromatic light, or light of one color. But we're going to talk about wavelength, because the light is often outside of the visible range. So it's not just a color. We're going to be quite specific. We talk about wavelengths of light. So if we have light of the right wavelength, and if the light is at the right color, the right intensity, and if we aim it in the right place for the right amount of time, at the right intervals, because often it needs multiple treatments, maybe 5, maybe 10 treatments, occasionally up to 20 treatments over maybe 2 or 3 times a week. If we get all of those treatment parameters correct, then we can increase the speed and quality of tissue repair. We can reduce inflammation and edema, and we can induce an analgesic effect. Most of the published clinical evidence is on sprains and strains and creaky joints and musculoskeletal pain. But there's also some evidence for its effects on shingles and post-hepatic neuralgia, trigeminal neuralgia, non-healing wounds, hard-to-heal wounds like diabetic ulcers and venous ulcers and pressure sores. There's some evidence for reducing pain in fibromyalgia. But probably the leading application in terms of published data is for oral mucositis, which is a side effect of high-dose chemotherapy and radiation treatment and hematopoietic stem cell transplants in cancer patients, with over 40 randomized controlled clinical trials published to date. If you've never seen any equipment before, then this is what our technology looks like. And then it's applied to a patient like this. So we aim light at the injury, and sometimes we choose to aim light at the lymphatic system to help drain inflammation and edema. Maybe we'll aim light over the spine to spinal nerves, to nerve roots, to peripheral pain, and we treat myofascial trigger points. So neuromuscular components of pain can also be treated with this technology. Now, this is not a heat therapy. The effects are more like photosynthesis in plants. And this is because humans and animals will photosynthesize. And you probably know this, but you might not have joined all of these dots together. But you know that when we go out in the sun, we change color. And you know that we use sunlight to help synthesize vitamin D. And you may know that they use blue light therapies for preventing neonatal jaundice on prematurely born babies. And you might know that dermatologists use ultraviolet light for treating psoriasis and vitiligo. So you should not be surprised if light has some other effects on the body. Now, normally your colleagues and friends and patients will associate lasers in medicine as being associated with cutting. Well, not all lasers are dangerous. That's because there's different classes of lasers. Some lasers are more dangerous than others. So there's class 1 lasers, for example, which are used all around you every day in supermarkets. They're reading barcodes and nobody gets hurt. The lasers you're thinking of in medicine, that your patients' colleagues might be thinking of in medicine, are class 4 lasers. These are the ones that have a thermal effect. We use class 3B lasers. They have no harmful effects on skin or clothing, though in theory they are potentially hazardous to the eye, so you and your patients should be wearing laser safety glasses. There is no reports, however, of any class 3B laser from photobiomodulation having an eye injury, but it is theoretically possible, so we recommend everybody uses laser safety glasses. We also use light-emitting diodes, LEDs. They've got some similar qualities to lasers in that they are monochromatic and they're reasonably high intensity, so they have some similar effects. But for the rest of this presentation, because we don't have enough time to go into detail, you will have to just assume that lasers and light-emitting diodes have exactly the same effects, because mostly they do. And if you want to understand the difference and understand how to do treatments, you're going to have to come and do my training course at some point. Details at the end of this slideshow. It's worth mentioning a little bit about history, which I'm going to do very briefly here. I'm not going to go through everything. Just to let you know that looking at this, the third gentleman on this slideshow here is Andre Mester. He had friends who had been working on X-ray therapies. They had developed cancers, and therefore he was wondering whether or not laser beams might cause cancer. So he does an experiment. He takes a group of mice, he shaves the hair from their bodies, and he divides them into two groups. And he puts a low-powered ruby laser beam on one group and not the other to see if the treatment group would develop cancer, and they didn't. And to his surprise, the hair grew back more quickly than on the untreated group. So he called that effect laser biostimulation. But as you can tell from that photograph in the middle there, he clearly didn't try it on his own head. Anyway, it takes until 2006 before any of the high impact factor medical journals begin to publish in this field. The journal Nature publishes an editorial on the mechanism of action, and the Journal of Pain publishes a clinical trial on neck pain. And then the World Health Organization, their Bone and Joint Task Force, start recommending lasers for the treatment of neck pain. And the Lancet published a systematic review of photobiomodulation for neck pain. The American Physical Therapy Association started recommending laser for Achilles tendinopathies. International Association for Study of Pain gave it strong evidence for myofascial pain syndrome. British Journal of Sports Medicine, strong evidence for frozen shoulder. British Medical Journal, tennis elbow, likely to be beneficial for short-term pain relief and improvement of function. And so it goes on. And I could jump down to 2017 because we don't have time for a full presentation, but the American College of Physicians, their guidelines for non-invasive treatments for acute, subacute, and chronic low back pain give it a strong recommendation. And 2017 again, Blue Cross Blue Shield consider it medically necessary for select patients and start reimbursement for it for patients at risk of developing oral mucositis after high-dose chemotherapy or radiation treatments for oral mucositis. In the UK, in 2018, the National Institute for Health and Care Excellence, the guidelines recommend photobiomodulation for treatment of cancer patients at risk of developing oral mucositis. And this year already, the Multinational Association for Supportive Care in Cancer upgraded their guidelines. They gave 3 good recommendations for photobiomodulation. This is for treatment for the prevention of oral mucositis and related pain for hematopoietic stem cell transplant patients, for radiation patients, and chemoradiation patients. And now there's over 700 randomized placebo-controlled clinical trials on photobiomodulation. There's more than 4,000 laboratory studies looking at the mechanism of action and the dose response. It appears in more than 200 systematic reviews. Last year, there were 443 papers on PBM published, and there's more than 6,000 papers in total published on this field. So how can one medicine treat so many different kinds of conditions? Well, that's because they all have something in common, which is oxidative stress. And we don't have time to go into how this therapy works. I'd love to talk to you about the glycolysis and the Krebs cycle, the electron transport chain, the terminal enzyme electron transport chain, and how that absorbs light, and how cytochrome C oxidase plays a role in oxidative stress, the production of ATP, and all the free radicals. But today isn't the day to do that. Again, you're going to have to come on my training course to understand all of that. But the short, easy summary of everything that happens is that when you're sick, when you're injured, when you're stressed, when you're old, your cells tend to be low on ATP, and they tend to be high in oxidative stress, particularly stressed inflammatory cells rather than non-inflammatory cells. But when we put this light into patients, the simple answer is this therapy tips the balance in our cells from being a state of low ATP and high oxidative stress to high ATP and low oxidative stress. And under these circumstances, patients heal more quickly. We've got some biomarkers for those of you who like this kind of thing. And here is a simplified map of what happens next. Okay, it's not simple, but okay, sorry, I didn't mean this to be a brag about my training courses, but you have to come and study this. I do an 8-hour training course on this topic that explains how light absorbed by cytochrome C oxidase in mitochondria, in stress cells, particularly inflammatory cells, has this profound anti-inflammatory effects that also stimulates increased tissue repair, reduces edema, it's anti-inflammatory, and as you're going to find out, there's a dose response. Not enough light, you don't have an effect. A bit more light, we get regenerative effects, we get anti-inflammatory effects. Too much light, actually, we slow things down. We can overtreat. We have inhibitory effects, which is very useful when we start talking about analgesia. So I'm going to talk about the regenerative effects for a couple of minutes. I'm going to talk about the inflammatory effects for a couple of minutes. We're going to talk about edema. We're going to talk about analgesic effects of this light. So 4 different topics coming up here. So an example, oral mucositis, the lesions, the ulceration, the severe ulceration. That means that people can't eat. They have to be fed by tube. Hematopoietic stem cell transplant patients in this study here, looking at 4 grades of oral mucositis here on the WHO scale. The grey bars represent the number of patients in each group. And as you can see, the highest grades of oral mucositis, the grey bar has high levels of numbers of patients in this study who have severe oral mucositis, grade 4. Those who are in the active laser treatment group are in the dark bars, and you can see most of those are in the low grades or no oral mucositis at all. This therapy is highly anti-inflammatory, and the Kaplan-Meier plot on the right-hand side gives you some clue to the size of this effect. Looking at head and neck cancer patients here, again, the grey line represents the pain scores for those patients who are in the placebo group, and the dark line represents those patients who are in the active treatment group. And it's obvious from this chart here that if you're in the active laser treatment group, you have far lower pain scores than those in the control group. And I have some before and after pictures here for you, showing a patient here who's going through radiation treatment. She's got oral mucositis. You can see from the top left-hand picture here, that is transformed after a course of treatment. You can see the radiation dermatitis is transformed before and after. And on the right-hand side, dry mouth. This by pre-treating preferably, treat patients before they have the radiation treatment. You can actually protect these glands from the radiation treatment. But you can see here, dry mouth before, but after a course of treatment, she's now making saliva. A side effect here from stem cell transplants, and we're showing a picture of a child here whose tongue here is showing signs of graft versus host disease. This is horrible. There's no satisfactory treatment for this, but for this child here, a course of treatment. He'd only had 4 treatments, and already he's shown good signs here of regression of that, I don't know what to call it, but the sclerotic tissues you see on his tongue. And now the Multinational Association for Supportive Care in Cancer guidelines, as I mentioned before, recommend this treatment for cancer patients to reduce the incidence and severity and reduce pain in the side effects of chemoradiation treatments. And in the UK, as I said before, our National Institute of Health and Care Excellence, who recommend, they write the guidelines for our National Health Service. You can see here that it says here, current evidence on the safety of low-level laser for oral mucositis shows no major safety concerns, and evidence on efficacy is adequate in quality and quantity. And Blue Cross Blue Shield in the United States are now reimbursing, saying it's considered medically necessary for prevention of oral mucositis in select patients. Here, this is at Dana-Farber. This child being treated here transcutaneously, having light projected through his cheeks into his mouth in the feasibility study with Brigham Women's Hospital, as we're working our way towards a large multi-center clinical trial across the United States to prevent oral mucositis in transplant patients, stem cell transplant patients. Here's a diabetic patient. This is a video. He had a hernia operation a year ago, and his wound has not healed yet. Projecting our light onto his wound, if you can see the video, showing that a few weeks later, there's good signs of healing. This is at Rochester General Hospital. And there's data. Here's an example, this little study here showing that projecting LED light onto these diabetic foot ulcers The first chart showing increases in healing rates, and the second chart showing increases in granulation tissue in the active LED treatment group. Another patient here has a 2-year-old pressure sore with a 6 centimeter deep cavity. They project some of our light into the wound, and what you see here, 5 weeks later, it's halved from 6 to 3 centimeter deep cavity, and now it's fully healed in 7 months. And this patient would have been costing $30,000 to $40,000 a year to look after. And here's a study from Sweden, the Karolinska Institute, showing that the amount of time to heal a pressure sore is halved when you project LED therapy, photobiomodulation therapy, onto these wounds. And another example, a venous ulcer. This is a Canadian study showing that in a control group, no significant change in the wound area or in these patients, but a significant area, wound reduction area, particularly in the first 4 weeks, a very rapid reduction in wound area in these patients. An acute wound here, actually it's one of a member of the company team, the THOR team, his wife purchased him this lovely little toy here, a circular saw. And you can see the date in the top right-hand corner, says 28th of December. So he took his lovely new toy from his wife and decided to do some home DIY. And you can see the state of his left-hand forefinger, where he's cut halfway through his finger there. But look at this. A week later, tremendous signs of healing on an acute wound. There it is a month later. And finally, a few weeks after that, April, look at the state of that finger there. I mean, it's looking close to being new. It doesn't just work on skin wounds. Here showing a fractured clavicle on a competitive sailor. She didn't want it plated. She thought it would reduce her ability to pull the ropes to pull up her sails. So she had her hands strapped up across her shoulder. The osteopath in London gave her a treatment, a course of treatments, and 3 months later, there's good signs of union, as you can see from this radiograph. And a randomized controlled clinical trial on fracture healing shows increased grip strength in the hand and finger in this study compared with controls, and 2-week follow-up showing that the differences have been maintained or improved. And here we have a graph showing motor function in soldiers who've had gunshot wounds. They have incomplete peripheral nerve and brachial plexus injuries. These injuries are at least 6 months old. Some of them are several years in duration. And then what you can see from the chart here, there's a significant improvement in motor function in the treatment group compared with controls. So, these are dental patients. They've had a third molar extraction. In case you don't know, but sometimes when a wisdom tooth is pulled, it'll break the mandibular, the inferior alveolar nerve that runs down the mandible. Here showing data from the brush stroke directional discrimination test. They're getting extremely low scores here. They get a course of treatment 3 times a week for 7 weeks. That's 20 treatments in all. This, by the way, these patients have had this paresthesia and dysesthesia for a minimum of 12 months. You know that if you haven't got recovery within 12 months, it's never going to recover. So minimum of 12 months to get into this study. And you can see here recovery for these patients. That wouldn't have happened any other way. I said there were anti-inflammatory treatments. In this experiment here, patients come to the therapist. They have to do exercises to aggravate their injury. These are tendinopathy patients. They do exercises to aggravate the injury, so it becomes acute and inflamed, and then they're given a laser. So they put a catheter in to the Achilles tendon, to the peritendon, to the tendon sheath. And then they're going to get a laser treatment or a placebo treatment. And then this chart here, the 0 point, this is the levels of inflammation in the tendon sheath before they have a laser treatment. Then they get an active laser or placebo treatment. And after 1 hour, you see on this chart here, there's increases in inflammation in the placebo group, but there's a reduction in inflammation in the active treatment group over the following 45 minutes. This is objective evidence in humans that this light is highly anti-inflammatory. Here we're measuring PGE2 concentrations in the tendon sheath. Osteoarthritis in this study here, there's 15 randomized controlled clinical trials for the effect of PBM on osteoarthritis. the left-hand chart showing a reduction in pain scores, but I'm interested in the right-hand side. This is osteoarthritis of the knee, and you see an increase in joint space in the active treatment group. It jumps from 2 to 4 millimeters increase in joint space, and there's no significant change in the control group. And the blood tests, if you look at the title of the slide at the bottom, the title of the paper rather, those are blood tests that confirm that these patients are making more cartilage, and that's why they have an increase of joint space from 2 to 4 millimeters, according to these MRIs. Now, this is data from a clinical trial. These are comparing laser treatments, photobiomodulation laser treatments, versus on-demand analgesics. And the analgesic in this case is coproximol, which is not around anymore, but it's opioids and acetaminophen combined. And showing here, they get one laser treatment immediately post-operatively. And the data in the slide here is showing that at day 2, 3, 4, and 5, that in the control group with placebo laser treatments, the consumption of coproximol is going up. But in the active photobiomodulation treatment, the consumption of analgesics, which is mostly opioids, is going down. Edema. So we're presented here with a second-degree ankle sprain patient. This is a controlled clinical trial of 47 soccer players with second-degree ankle sprains. They put their foot in a foot volumeter. So the foot volumeter obviously displaces water into this little measuring jug so that you can see the amount of displaced water, which equals the volume of the limb prior to a laser treatment. And then they are randomized to 3 different groups and into this enrolled into this study. They're either going to get rest ice compression elevation, so RICE therapy, if you like, RICE, or RICE plus placebo laser, or RICE, rest ice compression elevation, plus an active laser. For those of you with a video slideshow, can see that the greatest reduction in limb volume is in the orange bars there on the chart here, showing that the greatest reduction in edema, and it's significant. We're looking like 0.001 at day 3 in this study. I got some photographs from a customer whose husband had a skiing accident. He'd broken his clavicle here. You can see the plate on there. And when he gets home 3 days later, you can see the amount of edema around the wound. And she puts LED treatment on the wound. And then later that day, you see that all the edema has gone. Now, acute soft tissue injuries, edema, that's easy. But what about something more difficult? Breast cancer-related lymphedema, patients who've had maybe a mastectomy or at least radiation treatments, maybe they've had lymph nodes removed. This is there can lead to the swelling of the limb, so in the arm typically. And here showing that there is, in this systematic review, they say that there is moderate to strong evidence for the effectiveness of low-level laser therapy photobiomodulation treatments for the management of breast cancer-related lymphedema from 5 small acceptable methodological quality. So not just acute soft tissue lymphedema, but also in more challenging cases like this. And they tell me it works for primary lymphedema as well and lipedema. Analgesic effects. So in this experiment here, they're going to inject turpentine into the paw of a rat. They're going to attach an oscilloscope to the other end of the saphenous nerve, and then they're going to switch on a laser beam. And then we're going to look at the neuronal discharge. So over a period of 1 minute here, looking at this chart on the oscilloscope for neuronal discharge, on the left here, you see the point at which turpentine is injected. Then you see the increased neuronal discharge, as obviously it's pain for the rat. And then you'll see the neuronal discharge goes down at the point at which they applied the laser. This is like near instant analgesic effects in less than 1 minute. In fact, it's instant in terms of when the laser was applied. In this experiment here, we're looking at electrically evoked potential. So there is a probe going to the brain of this rat, the trigeminal ganglion. There is electrical stimulation of a tooth. And you can see the electrically evoked potentials measured in the brain. but when they apply a laser beam to the tooth and they apply the electrical stimulus, you can see substantially reduced electrically evoked potentials in the active laser treatment group. So what's going on here? Well, Roberta Chow, a GP from Sydney, Australia, did a PhD on the analgesic effects of laser radiation. She found 44 experiments that show that laser photobiomodulation reduces peripheral nociceptive input, so it means our nerve endings become less sensitive. She demonstrated that laser will inhibit fast axonal flow and reduce amplitude in these superficial C fibers and A delta fibers. So these are the fibers that transmit pain, and that this PBM treatment will also downregulate dorsal root ganglia, sympathetic ganglia, and the dorsal horn as well. So very useful in chronic pain patients. And it seems to reduce central sensitization and the causes of central sensitization. So you will remember before that I said there's a dose response. Not enough light, there's no effect. A bit more light, we can promote regenerative effects, we can have anti-inflammatory effects, but too much light and we lose the benefit. Except that this is when it works in analgesia. A deliberate over-treatment of the superficial terminals of C fibers and A deltas seems to have some interesting effects in reducing ATP availability in these nerves, which is the opposite of what I said earlier. I said PBM increases ATP and reduces oxidative stress, but not when you do an overtreatment. A deliberate overtreatment of nerves has the opposite of effect. We can actually reduce ATP availability in nerves. Again, if you come on my training course, I can explain that mechanism in a bit more detail for you. Couple of examples of dental pain. For those of you on the video here, might be able to see that here's somebody having a second molar extraction. Look away if you don't like blood or if you don't like dentists. This patient's had no anesthesia. He's only had an analgesic treatment. It is possible with an extremely high dose of photobiomodulation to actually have an anesthetic effect in these patients. Neuropathic pain, post-hepatic neuralgia. In this study, these patients have had the mean duration of pain of PHN is 2.5 years, 6 months to 8 years. They're going to get one treatment a week for 4 weeks. So the orange line you see here on the left represents the reduction in pain scores over the first 4 weeks. And then it's just a percentage change from 100% down to near 20%. Those who are in the control group have no significant change. It's a crossover trial. So then group B get the active laser treatment. You see their pain comes down to join group A. And at the end of 1 month, even group A, their pain hasn't gotten worse. And for 95% of patients in this study, they discontinued all medication. Yes, that's right. Post-hepatic neuralgia, one of the worst kinds of pain that you can get. People can't wear shirts, they can't line, they can't bear to be touched. And what we now know is that this is a pain that drives people to suicide. They've discontinued all medication at the end of the study with 1 month follow-up. At 6 month follow-up, 80% of patients maintain their pain reduction. Back and neck pain. This systematic review published in The Lancet, 16 randomized controlled clinical trials, 820 patients who had a mean duration of symptoms of 7.5 years plus or minus 3 years, with a mean baseline of pain intensity of nearly 57 millimeters plus or minus 7.5, for those of you who are nerdy out there for this kind of information. And as they are able to conclude, laser photobiomodulation reduces pain intensity, reduces disability, reduces recurrence. I'm told by the authors they found more evidence supporting the use of laser than any other intervention, including surgery, analgesics, collars, or mobilization, and that the mean pain intensity reduction compared with placebo is 23.4 millimeters. How good is that compared with, say, non-steroidal anti-inflammatory drugs? For musculoskeletal pain, non-steroidal anti-inflammatory drugs will give you 7 to 14 millimeters of pain relief. So 23.4 millimeters is clearly extremely good compared with standard care. Also, by the way, that's not the reason it's in The Lancet. The Lancet, as you probably know, is famous for being the journal for breakthrough medicine. Why has The Lancet published this review? It's not just because the pain relief was good. It's because there is no licensed drug of any kind in any country in the world licensed for treatment of non-specific neck pain. So in this review, it didn't just work a little bit, it worked extremely well in an area where, in a pathology where there is no licensed drug for treatment. And here's a video here of a neck pain patient, and you can look and see how far limited she can turn of her neck, maybe 45 to 50 degrees to the right, maybe 80 degrees to the left before treatment. Flexion, her chin down, and extending her head back there, very limited and very nervous in this video we're all watching. We give a course of treatment around her neck that takes 5 to 10 minutes worth of treatment, and then retest the patient. She's got a full 90 degrees worth of rotation to the right. You can see the smile on her face. And then if she flexes and sends her head, you can see that she goes back to an extraordinary 90 degrees of flexion. Can you believe that? There you go. A 10-year-old whiplash patient with non-specific neck pain. Example here, a patient who's got scoliosis. She said, I've been like this since I was 2. Really limited ability to rotate, can barely extend, flex or extend her head at all. And sort of flexing left and right, very limited. And for those of you watching on the video can see about 90 degrees rotation to the right and to the left. Massively improved flexion, extension, and rotation. As you can see, read from her lips, she said, it works. Chronic low back pain, British Medical Journal, 15 randomized controlled clinical trials and a systematic review, 1,039 participants, moderate quality of evidence, they conclude, clinically important benefits, significant pain reduction, in trials using at least 3 joules of energy per point, patients with a duration of back pain that is less than 30 months. So that's the end of the data. A couple of things to wrap up with here. We have a treatment library which shows you how to do all of these things. Of course, we have to mention side effects, safety and contraindication. Remarkably, there are no known side effects. There can be some short-term treatment reactions that last for some hours afterwards occasionally, but it's temporary and it's not significant. Of course, on the topic of safety and precautions, you should not stick laser beams in people's eyes. There's no evidence of anybody having an eye injury from photobiomodulation. We don't want people treating over a developing fetus in pregnant patients. A lot of people ask, how soon can you start treating patients? How young? In this image here, you can see a picture of an incubator with prematurely born babies. And here they are projecting red LED light onto, in this demonstration here, for babies who are at risk of developing a retinal, I forget what they call it, but a retinopathy in prematurely born babies. Here, they did a randomized controlled clinical trial where they didn't show an effect on retinopathy of prematurity. They did show, non-significant improvement in survival. It was 100% in the red light therapy group, 89% in the control group, and now this is going to a multi-center clinical trial to see if this see if they get enough patients, because it's possible that this therapy is actually improving survival in prematurely born babies. Photosensitive epilepsy, we do use pulses, and patients who have a photosensitive version of epilepsy can have a seizure triggered by flashing lights. So we suggest people do not use the pulse option. And cancer, of course, does it increase tumor growth or cancer cell proliferation? In vitro, it's possible to do it. Some in vivo models, there's been 95 safety studies on cancer, 13 show that you can, 82 papers show that you can't increase tumor growth or cancer cell growth, but these are in models where there's no immune system in them. The only data I think we can trust is this from human clinical trials. This study followed patients for 8 months after being in a clinical trial for oral mucositis. The active laser treatment group, for those that you can see the video here, show much better progression-free survival versus those in the control group over a period of 8 years. This is 108 patients over 8 years following being in a randomized control clinical trial. Your chances are better if you're getting photobiomodulation if you're a cancer patient getting radiation treatment. So in conclusion, PBM is safe, it's effective, it's available now, but FDA has no code specifically for photobiomodulation. There is limited reimbursement. It's only Blue Cross Blue Shield at the moment, and it's only for oral mucositis, but we're speaking with CMS next week about this. It appears in a few guidelines. I only know of one university hospital where it appears in standard order sets. I didn't have time to go through cost savings, but one hospital reports in oral mucositis patient it reduces hospitalization costs by 30%. So this is a new option for people with no hope, and it's more than just a form of pain relief. It's regenerative medicine. This is a treatment that actually helps people heal. And there's one more thing. We don't just treat the pathology. We have something that treats your entire body. So that's all, folks. Any questions?
James, that was terrific. Thank you so much. I guess it's one of the questions that I have is, it sounds so fabulous, and it's not necessarily as widely known as it should be. That's something that you are working on, Scott is working on, etc. But it may have something to do with the fact that of the regulatory status and the reimbursement status. But let me first go to the questions that have been posted along the way. Gordon was asking, in a rural area, what is the best way to find a qualified treating professional for neurosensory or osteoarthritis treatment?
Well, there's the answer today, and then there's the long-term answer. In the long-term answer, I don't know how this will be done. I hope that it's going to be in. My goal is that this is in every department of every hospital and every medical practice. So you would hopefully just go to your nearest family physician and get treatment. But in the short term, certainly if you go to our website, we keep a list of different practitioners with different skills who have treatment options around the world, depending which country he's calling from. I mean, this is our technology is in 72 different countries around the world. So, and then we will make sure that when you go to our website and you go to the Contact Us page, and there's somewhere an option about finding treatments, and then if you tell us what the pathology your patient has, we wouldn't want to send your patient to a veterinarian or to a dentist. We want to sell, if you're saying PHN, then we want to send postherpetic neuralgia patients to an appropriate doctor for that. So the website, thorlaser.com, which is on the slide in front of everybody now, to the Contact Us page, and we can help you find a treatment center near your patient.
Super. Scott asks, what is the usual duration of a PBM session, and how much do these treatments cost?
Typically, they can be as little as 5 minutes. They could be as long as 15 minutes, depending how big an area that how many points need to be treated. Typically, per point, they're like 30 seconds to 1 minute per point that needs treatment. That can add up to 5, up to 15 treatments. It depends. We've seen everything from $50 a treatment to $300 a treatment. Depends really what category of doctor, dentist, therapist, nurse is using the treatment, and also what part of the country that they are in. So, but that's the range, $50 to $300 per session, depending.
Bridget asks, we have a Novo Thor light bed. We receive a lot of questions from clients on the difference between ours and Juvie. So, right, Juvie, I guess it is.
Yeah.
That's the question. Do you have?
Well, I mean, this is a common question, really. So we're a company that makes equipment for hospitals and professional medical people, and we're highly regulated, and our products are subjected to independent studies in terms of their performance. And what she's referencing is an over-the-counter device. It's a wellness product that's not regulated, and I'm familiar with the product. By some good chance, we have actually taken that product in, and you measure what it delivers. And of course, not surprising, as with many medical devices and medical claims on the internet, the product doesn't deliver what it says it does. It's a long way short of what they say it does, and that's the problem with so much in the way of medical or pseudo-medical devices on the internet. It's just one of those things. So I don't know if that fully answered the question, but the answer is we make what we say we make, and you can't be sure that everybody else is achieving the same, but at least we're independently tested.
Michael asks, are different wavelengths used for this very broad range of applications?
Well, yes. So that's a good question because when lasers are very monochromatic, and you see studies that say, hey, this is 632.8 nanometers, and then another study says 650 nanometers or 660 nanometers or 670 nanometers, and another study says 800, 805, 808, 810, 820, 830 nanometers, and like, which is, people often ask exactly what's right, and is 810 better than 830 or 830 better than 10? And the answer is that broadly speaking, within a cluster, the red wavelengths, and I know doesn't know enough physics to understand that in the 600 range, light is visibly red. In the 800 range of nanometers, they are hard to see, if not impossible to see. They are near infrared. They're approaching the infrared spectrum. And is it important? Do these nanometers, give or take 5 or 10 or 20 nanometers, make any difference at all? And the answer is no. It seems that the difference between red and near infrared is not clear either. Does red work better than near infrared? When I'm in sort of full-on academic mode, I'd have to say that in theory, red should work better, but it doesn't penetrate so deep. That's why for subcutaneous, particularly for musculoskeletal pain, near infrared is the common wavelength to use because it goes deeper. Arguably, it shouldn't work as well, but it seems to work very well. And I could not say, honestly, hand on heart, that red is better than infrared. The wavelength, the data doesn't really support it, even though in theory it should work better. I can't say that it does. So near infrared, visible red, at least in the lab, are capable of performing the same results. There is a slight different dose response between red and near infrared. And near infrared does definitely penetrate deeper. I know that probably may start more questions than answers, but anyway, there you go.
Mustafa asks, how do you propose one should treat generalized pain or referred pain? Must there be a photobiomodulatory effect at the nerve ending or pain receptor level for the photochemical modulation of pain to take place?
Right. So, it's very often the pathologies can be quite deep. So we've got multiple effects going on here. First of all, if the work from Roberta Chow, the GP in Sydney, Australia, and her PhD on the analgesic effects of light, her view is you only have to reach the terminals of C fibers and A deltas, and that has an effect downstream all the way back to the spinal cord. So you only have to reach the superficial terminals of C fibers and A deltas to have an effect on the whole nerve, and not just that one nerve. It affects the entire dermatome, sclerotome, myotome as well. So superficial treatments have a very broad effect. And the effects are not just analgesic, they're anti-inflammatory. So if you can get light anywhere close to the pathology, you have these analgesic anti-edematous effects, which take about, and by the way, the analgesic effects are almost instant, it happens within seconds or minutes. The anti-inflammatory effects happen within, and the anti-edematous effects happen within hours. You can also, if you can't even get the light to the pathology, treating the lymphatic system, which is very often, lymph nodes are very superficial, you can treat them and they have downstream effects. So I've done analgesia, edema, and trigger points. Also, my neuromuscular treatments. Sometimes this referred pain that he talks about here, particularly myofascial trigger points. You palpate a tender area, but you get this referred pain somewhere else. And if you find the origin of the trigger point, yes, you treat the origin, and you seem to deactivate these distant, these referred pain signals. So you've just got to find the origin of this neuromuscular problem. But we didn't discuss whether it was pain due to neuropathy or neuromuscular or traumatic or whatever. So it's I didn't know how to answer his question specifically, but I know I talked around it a lot, but that's what I have for now.
Josh asks, where can practitioners go to get hands-on training?
It feels like it's been straight into my lap here, because here on my remaining slide here, just the thorlaser.com. There's a tab there that says training, and you click on the training tab, and then you can see all the training courses there. So, and they're across the world. We do the United States, Canada, Australia, and Great Britain. There are main areas, and occasionally other countries.
Sergio says, congratulations. I could summarize that photobiomodulation works like a tempo machine where we try to return to the moment when everything was better? Question mark. Maybe it's a time machine. I'm not sure. Go ahead.
That's obviously that's an esoteric way of expressing really returning to homeostasis, to returning back to more sort of conventional medical physiological terms. What light seems to do under these circumstances, what it does to mitochondria, seems to return homeostasis. This is why I talked about stress cells. Stress cells have a big response to this light, and so basically the short answer is it seems to return homeostasis, which I guess is getting to his point.
So I don't see any more questions for the moment. I do want to return to the question I started with before. James, what do you see as the future development of this technology, given that it hasn't gone the route of FDA approval for medicines? I'm very impressed by the number of clinical studies that have been published, but they haven't gone through a regulatory process. Would you say that that might explain in part the fact that it's not as more widely prescribed or used, I should say, or is that kind of not so relevant? I'll make an editorial comment. Zan made a reference to our conference last week on metabesity, where there was a somewhat similar or evocative question about going through a regulatory process for medicines and for foods versus making claims based on published science for healthy longevity. And it's an interesting question for me, these two different approaches for spreading medical technology.
Right. So I'm in a studio where they're going to kick me out in 25 seconds.
Okay.
I'm in Barcelona, just this rented space here. So it is FDA cleared. What they've done is they've adjusted what used to be an infrared lamp, what do you call it? Code ILY. So we are a medical device. We have to meet all the regulatory requirements for making medical devices. It's being allowed in as a version of a heat lamp. They've expanded the meaning of infrared lamps, and not just heating, but near infrared energy and visible red light. They've even created a new code called the non-heating heating lamp. Yes, you heard me right. The non-heating heating light. Where you can get this technology approved for specifics. It's probably, most people don't understand the difference between getting a 510K. So we have a 510K approval for this. It was called clearance, actually. It's 510K clearance. And when I did mention, I have an interest in a company called Lumithera, which is another light therapy company. We're going through a PMA, which is what drugs have to go through. We are going through a PMA to prove this technology for the improvement of visual acuity in dry, age-related macular degeneration patients. So PBM is going through that route. So I agree that at the moment we get in under the wire through a 510K that was originally intended for an infrared lamp, and here we are. Photobiomodulation is easy to get clearance for temporary relief of muscle and joint pain, and that's where most of these technologies are on the medical market for that. And we have to have GMP, good manufacturing practice. We have all the audits, we have all the unannounced audits, we go through independent testing to get this thing. It goes through the same requirements of any medical device, and we get this mediocre review. They park us there. Again, I'm meeting CMS next week. We're working on my meeting with the FDA to see how, other than PMA, which is a tough route to go, but we are doing it through Lumithera for macular degeneration, and it will be a hardcore mainstream medical treatment for dry AMD. And we've got to find out how best to get there for oral mucositis, which is probably our leading application at the moment in the United States.
So it now being past the noon hour, James,
Yes.
I want to thank you so much for your very clear and instructive and revelatory presentation. Again, for the listeners here, the webcast will be posted and the links distributed by early next week. Well, we'll eventually make a YouTube video out of the presentation, but at least the slides will be posted. With this, James, we want to thank you for this terrific session and for the attendees, your attendance and the discussion. And we wish you all a good day and a great weekend.